So, yes, I will be talking about happiness, but most of all, I will today be talking about the opposite of happiness. Is this working? I don't think it is. Oh, sorry. There we go. So when we talk about happiness and when we refer to happiness research, we need to understand that happiness is like a very elastic suitcase concept. So we can measure happiness in various ways. But the measure that is often referred to, and the measure I will refer to, is what we call life evaluation. It's also the measure that's adopted by the OECD and the United Nations when they make these country rankings. And there's different ways to measure life evaluations, but this is a very common one. It's the exact one that is adopted by the United Nations, and it asks people to rank their life on a scale from 0 to 10, where 10 represents the best possible life and 0 the worst. When this is done in a population, we find that the highest averages is in the Nordic countries. But an average is quite problematic because an average hides a lot of information. An average hides information about distribution, for instance, so we don't know anything about how many people are actually suffering in the Nordic countries based on that average. So a way to kind of illustrate this problem is to imagine two countries. So imagine a country A and a country B. In country A, half of the population have a well-being score of 8 and the others a well-being score of 6. And in country B, half of the population have a well-being score of 9 and the other a well-being score of 5. So that means that both countries have an average of 7, right? But there's like a huge difference in terms of disparity in the two countries. That makes sense, right? And that information is kind of important, and that information is left out when we look at those country rankings. But just to make a little fun kind of Rawlsian exercise, I would like to ask you which country you would rather live in. So imagine that you're not yet born and you get to choose which country you get born into, and the only catch is you don't know which part of the two populations you'll be born into. Would you then choose country A or country B? So everybody who wants to live in to be born into country A under those terms, raise your hand. And country B? No one. All right. So we asked more than 1,000 people on Facebook to answer this exact same question, and the distribution of answers were very similar. So 92% would go for country A, and 8% would go for country B. The interesting thing is that men are 3 times as likely to go to country B as women. So some would say that this kind of explains, or this touches upon like some ethics and some justification of some egalitarian concept or approach to society. I think that may be true, but I think most of all it gives us some idea of loss aversion. So in decision theory, we know that people they prefer to avoid loss over gains. Similar gains. And I think that's actually kind of what's going on here. But if we look at the country rankings again, so the country rankings by the United Nations always put the Nordic countries at the top. And this is subjective data. The interesting thing is if we look at like more objective data on social progress, we find the same countries to be in top 10. So it's really nice actually that we find that the subjective data matches the objective data so well. It tells us that the things that we believe are good kind of promotes subjective well-being as well. Some would say that the common denominator between all these countries is wealth. So it's wealth that is driving happiness more than anything else. And that's to some extent true. So if we look at countries, GDP on the x-axis and happiness on the y-axis, there is a sure link between wealth and happiness, but it's kind of diminishing. The effect, the return on happiness from high GDP is diminishing. So what we can say is that we know that small gains in GDP per capita are associated with large changes in well-being for poorer countries, but for richer countries, much less clear. What we also see is that countries with similar GDP per capita levels can show big differences in average well-being. And in the same way, countries that had very different GDP levels can have the same average of well-being. So it's not a clear correlation. There's a lot of outliers, and there's a clear kind of diminishing return. What we can draw from this is that as soon as we get to some level of wealth, it's not any longer a law of nature that more growth will provide more well-being for the population. In fact, we find a lot of incidents where it's the opposite case. It happens in Indonesia, in US, and it also happens in Denmark. So since 2005, the average happiness levels have decreased. This is the only Nordic countries where this is the case. But since 2008, we have had quite positive growth levels. So we have this decoupling between wealth and happiness in Denmark. So all of these problems, the fact that there can be a decoupling and the fact that the averages hide and mask a lot of valid information, we, together with the Nordic Council of Ministers, have done the report, The Shadow of Happiness, where we are trying to understand who are the people who are not happy in the Nordic countries and why. The most important question is the why in my perspective. But just to get you through some of the findings, we find that people who are suffering or struggling, so it's people with low scores, it's around 12% in the Nordic countries, but it varies with age. People between 18 and 23 and people above 80 are more likely to be suffering. The good news is that these numbers are still the lowest in Europe, but there are indications that they may be growing for some of these age groups in the Nordic countries. The reasons why that the young people are suffering more is also dependent on gender. So we find that mental health may be a bigger problem, or is directly linked to misery for young women. It's not so clear in Iceland, but it's very clear in the other countries. But when we look at young men, or men in general, it's much less clear. And we have not found a good predictor, actually, of the unhappiness for young men in the Nordic countries. What we also find, this is not so surprising really, but we of course find that people who are job seeking are more likely to be suffering and struggling. They are actually often in this category. And people who are chronically sick and disabled, we find the same patterns. So not so surprising really, but and the last one, poor social networks are also an indicator of unhappiness, and it's more prevalent the older you get, especially for men. But the interesting thing here is that this is the only way we have been able to measure the social functioning from the European Social Survey, which we have used for this study. But if we measured loneliness instead, so my theory is that if we measured loneliness, which is different from social networks, right, we would find something else. So if we look at the Danish data from Sundhedsprofilen, that is a representative sample, we have a representative sample for the whole population, we find that people who are most often experiencing loneliness is actually young people, and then we get like a reversed picture of like how we are socially suffering in the Nordic countries. This is the main conclusion of the report. So what we did is we built a regression analysis where we pulled in all the different variables trying to explain misery, why some people are unhappier. So we don't explain happiness, we explain the disparity. And we try to look at which kind of disparities are explaining happiness disparity. So is it physical health, income disparities that explain why people that we are divided in terms of happiness? And this is the ranking basically. So we find that physical health and mental health are by far the most significant factors, by far the factors that drive and that divide us the most in terms of happiness. Income number 3, then employment status, so different employment status, and social network. And actually I have forgotten number 6, there are 6 significant factors, and number 6 is religion. So we actually find that people who describe themselves as very religious, they are protected against misery, you could say. They are more or less likely to be miserable in all Nordic countries. So these are, of course, interlinked as well. So this is like the pure effect of each of them when they are interadjusted in a regression. But, of course, they are also linked. So we know that physical health and mental health is very, very linked. The interesting thing is this has also been done by Richard Layard on a global scale, and he finds very similar results. So we have actually adopted his methodology and done it in Nordic countries. He did this before we did, and he finds that mental illness and physical illness in high-income countries are by far the factors that explain some disparity in well-being. And mental illness is also the most prevalent factor together with income in upper middle income countries. And income starts to become more and more a factor, of course, as the poorer the countries get. So the takeaway here is that happiness inequality offers this comprehensive measure of inequality that subsumes the many and various components forms of inequality. And in the Nordic countries, we find that the component of inequality that explains happiness inequality the best is health disparities. So in this report we did with the Nordic Council of Ministers, we kind of scratched the surface, but we have also at the Happiness Research Institute taken some deep dives into some of the groups. We have this theory. It's not really a theory. We have a lot of evidence suggesting that the people who are suffering the most in the Nordic countries the group of people who are suffering the most is people with chronic diseases. So we have done studies on this. One study is, or the study we have used the most time and efforts on, is a psoriasis study we are doing annually. We've done 2 reports. We've worked on it for 3 years. We have collected data from 80,000 psoriasis patients across the world, across 21 countries. And in Denmark, we have a sample size of 1,500 psoriasis patients. So it's a really good sample size considering that there's 160,000 psoriasis patients in Denmark. Psoriasis is this autoimmune disease that affects your skin as well, but it's an autoimmune disease, it's not a skin disease. It has a lot of horrible comorbidities as well. It affects your life in various ways, and it's, I think, 2 to 4% of the Nordic population suffer from this disease. What we find is that people who live with psoriasis in Denmark are 22% less happy than the general population. So by using the exact same measures as the UN, we can actually compare to the general population, and we can find how big is the difference between people living with psoriasis to the general population. The difference is 22% in averages. And the interesting thing is that's one of the highest differences we find across the 21 countries. The people who are chronically ill in the Nordic countries are less likely to become more unhappy than if you were ill in another country. Does that make sense? It's a bit complicated. We have a lot of theories to why that is the case. I'm not going to go into that. But the happiness gap we find is mainly explained by poor social functioning, stress, poor mental health, and poor healthcare. We find that 26% who live with psoriasis also have a mental disorder. This is very much similar to many other diseases. We have some studies in the UK that shows that on average people who have a chronic disease, 30% of those are also suffering from a mental disorder. So this is very similar. But we also find that you are twice as likely to experience high stress. Again, we are comparing to the general population. We're using the Cohen's perceived stress scale. And you are 6 times as likely to experience loneliness. Again, comparing to the general population, where we're using this UCLA loneliness scale and then using it for psoriasis patients in Denmark. And 58% do not experience that the healthcare professional recognizes that psoriasis affects mental health. This is quite a lot, and it's kind of suggesting that the mental health care and physical health care is still very separated professionally, culturally, and institutionally, and that is very much perceived by the patients as well. You could say that 58% is maybe not that high, given that the 42% is who are then saying, yes, I actually experience this, if those are the people who need the help. But what we find is that the people who disagree that their healthcare professional do not recognize how it affects their mental health is also the people who are unhappiest. And this is we find this across all countries we have surveyed. So the argument is that if we want to bridge health-induced happiness gaps, we should address happiness directly in our health economic evaluations. One would say that we already do that. And that's true. So happiness and quality of life is actually at the core already at health economic evaluations, also in applied health economic evaluations. Some of the most used measures in health economic evaluations are the SF36 and EQ5D, which are used to inform the QALY. I don't know how many of you know the QALY, but the QALY is the Quality Adjusted Life Years, which is used in many countries to assess the efficiency and effectiveness of health interventions and also medicine. In some countries they use it a lot. In UK it's used to a great extent, and is actually the measure that all health interventions are to be tested with the QALY, and the cost efficiency or the cost effectiveness is to be evaluated. And if it's not cost effective based on the QALY, then it's not being implemented. There's more measures, but it's to approve interventions in UK, but QALY plays a huge role. So the quality of life measures are really at the core of health economics, also applied health economics. But the EQ5D, which are informing the QALY, which are used, is supposed to be a great proxy for well-being, but I would argue that it's not. The same goes for patient satisfaction, which is also used and measured a lot, also in the Nordic countries, at least in Denmark. We measure it annually. We make these huge reports, and we measure patient satisfaction and patient experience in order to improve the quality of life for the patients, or at least that's how it's communicated. But I would say both are very bad proxies of well-being. So the EQ5D, which are used to inform the QALY, ask about 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. So this seems reasonable that these factors are important, right? But the problem is there's no good normative or empirical basis for claiming that these 5 dimensions are equally important. But they are evaluated in that way. They are evaluated as they should be equally important. 2, these 5 dimensions are the only important ones. There's no normative claim for that as well. There are several factors you could include that you could argue is important as well. Vitality. So they've actually been expanding it to also include vitality. But I would say there's several factors that could also be embedded. And perhaps you should even elaborate, or you should expand like the different mental sides and not just put it in one question. And finally, for the QALY, the preferences are based on elicitations from the general population, who we know consistently exaggerate the impact of pain and underestimate the impact of mental health. So there's lots of problem with the methodology as well. So what we can do, there's studies that have tested the EQ5D in surveys where they also asked about happiness and quality of life, like on a general scale. And then we can make some quite interesting correlations to see how well does these actually predict general happiness, which they are supposed to do, basically, right? And what we find is that there's a major significant effect on happiness from anxiety, depression, and usual activities, and there's no significant effect from mobility. So already there, we are starting to see some problems. And many would argue that you should perhaps either embody or apply happiness directly in these measures, just measure that perhaps, because that actually captures a better variance of how people experience lives, or we should revise this based on some of these correlations we can make. So the conclusion is that mental health and social functioning are consistently underrated in health assessments. We find this not only in the EQ5D, but in all the health-related quality of life measures. I have just brought along the DLQI, which is what we are up against when we did the psoriasis study, because the DLQI is what has usually been used for psoriasis patients in clinical trials. It's used in thousands of scientific articles in clinical trials to assess the efficiency of different health interventions for people with dermatology issues. And it's the same problem applies. These, I would say, are not equally important for happiness, and we have no good normative or empirical basis to claim that these 10 are the only important ones. You can probably guess because we have then done the same test and seen how does these actually correlate with happiness for people with psoriasis, because we have it all in the same sample with 80,000 people, right? And what we find is that how embarrassed or self-conscious you've been because of your skin and how much your skin affected any social or leisure activities are by far the factors that actually explain the variance. And several of the factors don't have any impact when you look at a general, like the population of psoriasis patients. That applies to how much people, whether your skin has made it difficult for you to do sports, and whether your skin has been influenced by the clothes you wear. So again, we get the same problem here. I will go to patient satisfaction here in the end. So patient satisfaction, as I said, is something we started to measure more and more, and I'm not sure why. It's probably part of this wave where we start seeing patients more as consumers, which is, in my belief, problematic in many ways. But the big problem to me is that it's often communicated as a tool that ought to promote quality of life for patients, starting to measure their experience with healthcare and the healthcare professional, and and their satisfaction, then we can actually figure out how we can improve the healthcare and the quality of life for patients indirectly through better healthcare. The problem is that is a really bad proxy for patient satisfaction is a really bad proxy for patient happiness. We find that they are in some countries not at all correlated, and in some countries poorly correlated. We're not sure why yet. We have done some different tests, and one thing that seems to partly explain it is this. So on the x-axis, we have how often you are involved with healthcare, how often you go to see your healthcare professional as a patient with psoriasis. So you are in a treatment, you have a treatment plan, right? And what we find is that the more you go, the unhappier you are, and that kind of makes sense, right? Because it probably tells a story of that you have a bigger need because you're more ill. But you've actually controlled this for severity, so it's probably how you experience it yourself. But it makes sense, I would say. You go to see the doctor more if you have a bigger need for it, and that's probably a proxy for unhappiness. The problem is that patient satisfaction goes up the more you go to see you go to see your doctor as a patient with psoriasis. Why that is the case is difficult to assess. This is on average, right, based on all people with psoriasis we have assessed in these 22 countries. And you could argue, a theory is that you perhaps you become more comfortable with the system, you become more comfortable with your healthcare professional, and therefore you become more satisfied. And when you don't go there, and when you never go there, there's nothing to be satisfied about, so therefore you just put like a low score. But the problem here is evident, right? So patient satisfaction has nothing to do with patient well-being. And in fact, when we try to build regression analysis to explain the two, we find that it's also different factors that explain them. So patient satisfaction is very much explained by your information. So if you feel that you get a lot of information about your disease and the different treatment types, you can become more satisfied. But for patient happiness, it's more about welfare, number one, and it's more about feeling understood, that your healthcare professional listen to you and understand that this is something that also affects your mental well-being, even though it's a physical condition. So to sum it up, happiness inequality is primarily driven by health disparities in the Nordic countries, but this also applies to several other countries. And if we can agree that a main welfare imperative is to focus our efforts where well-being is the most scarce, then helping people with health problems should be a priority. I think this is already a priority, and I think our system is built this way, right? But the problem is that the conventional practice in health economic evaluation and patient satisfaction evaluations are too narrow in the way they think about quality of life. So therefore, I believe, we believe that we should strongly consider happiness research and its applicability to valuing health for the purpose of better understanding what really matters to people, and eventually and ultimately for use in economic evaluations. Thank you.